Alright, let's finish up chest trauma under chapter 32. When reading chest trauma, we will discuss each of the four, I believe, listed here. One, two, three, four. Right. Now, imagine that they can occur individually on their own, but most probably in severe trauma. So, let's say in a war zone or in a major accident, for instance, they can occur together. So, let's begin. Pulmonary contusion is actual direct injury to the lung, as you can see here. It's the most common chest injury when you have car accidents, for instance. And if you remember in respiratory failure, this was one of the causes that can lead to ventilatory respiratory failure. However, this was also listed under the causes for ARDS in the form of acute lung injury. So questions on the exam will be basic signs and symptoms. How do you recognize a pulmonary contusion? And then next is interventions or management. So if you read here, what happens is there will actually be direct injury to the lung, either caused by a penetrating object or a blunt force injury. The blunt force injury here can be caused by a broken rib, for instance, or multiple broken ribs, which will either pierce or lacerate the lung as a result of the trauma. So your symptoms will either be asymptomatic at first, especially if there is closed chest injury. However, the patient may develop secondary injuries later as the lung tissue starts to get inflamed, swell, and then of course you will have signs and symptoms such as decreased breath sounds, crackles, wheezes. Other external injuries will be bruising over the injury, meaning you can see it over the chest wall. Patient develops dry cough, tachycardia, tachypnea, and as already mentioned, the x-ray at first may not show any injuries, but later when the patient develops respiratory failure, then you'll see signs and symptoms of such either respiratory failure and or ARDS. Management are the following. First of all is give oxygen, fluids because there's most likely bleeding. Of course, position the patient head of the bed elevated. When there is unilateral lung injury, we always position the patient good lung down when side lying. And the management will either include non-invasive positive pressure ventilation, meaning BiPAP or CPAP, or in severe cases, then the patient will have to be intubated and put on a vent. And as I already mentioned, the patient may develop acute respiratory distress syndrome because this is how, after all, direct lung injury. Rib fracture. Rib fracture is if this is the broken segment is only in one part. So let's say this is your patient. Our ribs are attached. Just imagine this is the sternum. Okay, and then we have ribs attached to this anteriorly on the sternum, and then you have the spine. Just imagine this is your spine. Okay, so it is attached posteriorly to the spine. Let's extend this a little bit. Okay, so this is therefore anterior, and then you have posterior attachment to the spine. Okay, now in um, rib fracture, the patient will either have a non-displaced fracture or a displaced fracture. Either way, as long as it is only broken in one segment, there will still be lung expansion. So if you imagine your let's use this color. Okay. So let's say this is your lung inside, okay, the rib cage. If there is only one broken section, meaning as the diaphragm contracts, diaphragms here, as it contracts, it will still allow air to be sucked in, so there will still be lung expansion as long as there's only one broken segment, meaning it will still move, there will still be lung expansion. However, of course, there will be pain as imagine a baby back rib. So if you have a you've gone to the a restaurant, had a rack of ribs, the ribs are attached to muscle. Okay, so as the the diaphragm contracts, so lungs will still expand, and the chest wall, the thoracic cavity, will still move. It will still, you still have chest expansion because they are held by your chest wall muscles. Okay. Now in the other problem, let's finish the signs and symptoms first. The only symptoms here will of course be pain on movement, and the patient instinctively splints the chest as they breathe because there is pain. Okay? And that will of course limit the chest expansion, the pain I mean. However, if the patient um, if the fracture is, let's say, displaced, the patient may develop either pneumothorax or a hemothorax as the displaced rib, as one of these displaced ribs punctures the lung as a result of continued breathing. Then you will have laceration to the lung. There may also be pulmonary contusion, but most likely there will be a tear or a hole on the parenchyma, resulting in either a pneumothorax or air in the pleural space, or a hemothorax, which is blood. Okay, most likely patient may have both a pneumo and a hemothorax. The only difference is pneumo, of course, is air, so it will go up. So most likely the pneumothorax will be found in the upper lobes, whereas the hemothorax, it's blood, it's wet, so it will be found further down in the lower lobes. Management: if it is a simple or uncomplicated rib fracture, they typically don't need a surgery because it will heal spontaneously. We do just need to support ventilation, because again the respirations will be shallow because of the pain, and because there's pain, so there will be pain management. In most cases, the patient may be in severe pain, the patient may receive an intercostal nerve block, where they'll inject a anesthetic, okay, local anesthetic to the chest wall. Sometimes they'll have a infusion. Okay, there will be a catheter inserted, which will deliver your nerve block. If it is severe, meaning not just it's a complicated fracture, then the patient will receive surgical repair, which involves just like orthopedic surgeries, they'll put screws or plates, rods in severe cases, then to repair the fracture. Take note that splinting reduces breathing depth and clearance of secretions. So typically we don't, especially circumferential splinting, meaning we don't put a bandage around um, the patient's thorax, because that will further limit the chest expansion. A flail chest, on the other hand, as described here, there will be two neighboring ribs in two or more places that are now broken. So think of this as um, here. If your rib fracture this time involves two segments, meaning instead of just being broken in one spot here, you now have two, at least two or more. Okay, so as a result, again, remember your baby rack of ribs. Okay, now this section here, and this other section here, this one and this one, are still attached to the sternum, and the other side is attached to the vertebrae. So as the patient breathes, as the diaphragm contracts, there will still be lung expansion. However, because you have an independent section here, you have this independent broken segment, then there will be paradoxical breathing. As demonstrated here, the patient, therefore, when they breathe in, because there is this independent section that nothing is holding, meaning these are just attached to the muscles. Therefore, since they are no longer attached to the sternum nor the vertebrae, nothing is holding that area. So as a result, the chest wall will sink in during inhalation and then puff out during exhalation. I'll show you a short video. Of flail chest. You'll see this one, for instance. This one is, as you can see, there may be multiple ribs involved here because it's quite a large um, sinking. Okay, so the patient, every time they inhale, it sinks in, because again there are multiple here segments that are independent. So this is what we call paradoxical chest movement. It may not seem bad, but if you imagine inside, the mediastinum is right here. The patient's heart um, is in the center. So therefore, there will be hemodynamic um, problems here, because every time the patient's chest wall sinks in, it will compress the mediastinum. See how it shifts here? So every time the patient takes in a deep breath, the big vessels here, the superior and the inferior vena cava, if you have your heart right here, are compressed. The whole heart is compressed, so you will be seeing mediastinal shifts, so that will severely impair venous return, and therefore it will also impair cardiac output. So definitely, you'll have, of course, your signs and symptoms will be the paradoxical chest movement. That is the hallmark of a flail chest right here. So there will be severe dyspnea, cyanosis, tachycardia, and severe hypotension. This is actually the cause of death here will not be the flail chest, but rather the patient will die from shock, particularly obstructive shock, because there is a mechanical um, obstruction on the heart. There was mechanical pressure exerted on the heart. As a result, there will be um, very low blood pressure as a result. Interventions, of course, on top of oxygen, this patient will require um, suctioning, and most likely the patient, if not already intubated, will be intubated and put on a ventilator. And if you can imagine the video you just saw, most likely the patient will also have a hemothorax at the same time, because with multiple rib fractures like that, of course the fragile lung has most likely been injured as well. So you will have pulmonary contusion, a pneumothorax, and even a hemothorax occurring at the same time. Or um, the patient here, and of course, let's finish flail chest. The patient will, of course, need surgical repair as soon as the patient is um, hemodynamically stable. And then, of course, surgical stabilization will involve rods, plates, screws, okay? And at the same time, the patient will have a chest tube. We'll discuss chest tubes in the second hour. We'll hopefully be in school by then. Please read the rest of your management. As I said, the patient most likely will have contusion, pulmonary contusion. So we give oxygen, IV fluids here, of course, is part of blood pressure management, pain management, nerve blocks again, and then surgery. As far as a pneumothorax and a hemothorax, again, this is air inside the pleural space. Okay, so what happens is you lose negative pressure in the chest. So let's review again how we breathe. So as you remember in A and P, we breathe through our diaphragm. So we have our breathing muscle here. The diaphragm contracts and air is sucked in passively into the lungs, and we have a pleura here, a pleural sac. Okay, please use your imagination. Of course, this sac is very thin. There are two sides to it. There's a this one here, the outer is the parietal pleura, and of course the one attached to the lung here, there's a sac there. The other side of the pleura is called the visceral side of the pleura, and there is a very small amount of fluid circulating here, constantly being produced and drained. So any moving organ of the body, of course, has a sac containing fluid which will lubricate it, preventing friction. So the heart also has a sac. As you remember in third semester, we talked about pericarditis. So we have the pericardium. For the lungs, that's the pleura. We have the peritoneum for the entire abdominal cavity, and the testicles have a scrotum. Okay, so everything has any moving part has a sac with fluid in it to prevent friction during movement. Okay, so the air here in the case of a pneumothorax, or the blood in the case of a hemothorax, is in that space. Okay, so let's watch let's explain it first. So you either have a hole here, so let's say we have a stabbing injury. Somebody got stabbed with a knife, or a gunshot wound, for instance, or a spontaneous pneumothorax. A spontaneous pneumothorax are caused by blebs. The risk factors for blebs are severe COPD, and also tall, lanky individuals, male or female. They are prone to um, forming blebs. Blebs can be single or multiple. These are air-filled blisters. Okay, that's the best description I can give. They form blebs on the surface of the lung, and these can spontaneously rupture. In that case, of course, this one is non-traumatic. This is caused by this is what we call a spontaneous pneumothorax. All the rest, the other types are, of course, either traumatic. Yeah, all other types are traumatic pneumothorax or traumatic hemothorax. Please read the simple versus a massive hemothorax. Here is just determined by the amount of blood forming inside the pleural cavity. Now, so therefore, the way we breathe is negative ventilation, right? We are negative pressure ventilators. Now, the only way we stay negative ventilators is if the chest wall and the pleura are intact. Now, once we disrupt the the negative pressure, positive pressure will start building. So if you have either blood here, blood forming here, okay, and the more blood that collects there, therefore this lung will start to collapse. Okay, as more and more blood collects, my pen's giving up. So if you have more blood collecting, then the lung, of course, will start collapsing. So and then if you have air up here as well, so if you have air here, so that will further collapse the lung. If you also have air accumulating here, right? So that's how a pneumothorax or hemothorax kills the patient, because of lung collapse, meaning there is no way for the lungs to expand because there is so much positive pressure occupied here. So you have positive pressure there now instead of negative, so breathing becomes very hard. The patient exerts so much effort, but yet can't get enough gas exchange. A tension pneumothorax here is an emergency. We have a video here. So whenever you have a condition wherein the pneumothorax forms and there is no way for air to escape, such as in this instance. Look at the lung here. The lung gets smaller and smaller as your positive pressure builds up. And just like in a flail chest, this one will, of course, as the lung collapses and as more positive pressure builds here. Look at the mediastinum, it is also shifting. And again, your large vessels here, your superior and your inferior vena cava, are naturally compressed. So this is again another cause of obstructive shock. Patient will die in a few minutes unless there is emergency needle thoracostomy, meaning there is no way for the air to escape. Okay, in this case, the patient will surely die from shock. Signs and symptoms, of course, we divided it here. If it's only pneumothorax, not a tension pneumothorax, these are your signs and symptoms. The patient will have dyspnea, of course, and then you won't hear any air movement on the affected side. Okay, so there is hyperresonance because the lungs are not inflating; they are collapsed. No breath sounds, and then there is prominence on the involved side, meaning it will be kind of enlarged. However, there is no chest movement as the patient is breathing. It won't move. Only the other side will move. In severe pneumothorax, there is tracheal deviation, okay, but no um, major hemodynamic effects yet. In a tension pneumothorax, now you have extreme respiratory distress, cyanosis, and then there will now be distended neck veins as the superior vena cava is compressed. Of course, hemodynamic instability, the patient will have severe hypotension leading to shock. So because the patient could die within minutes from shock, so now the patient needs, as I mentioned earlier, immediate needle thoracostomy. So this is the insertion of a large, probably 14-16 gauge needle. They will insert it in the second intercostal space. So this will allow the air that has accumulated here. Of course, air will always go up, so that's why they put the needle on the second intercostal space, mid-clavicular line, on the affected side. So that will immediately decompress the chest wall, and then this will always be followed by a chest tube insertion. The chest tube will continuously remove air and or blood in the pleural space. Okay, we will discuss chest tube management in the second hour. Because the chest tube is necessary because the needle, we can't keep the needle there long term. Plus, it's a very small needle. Its purpose again is just for emergency chest decompression, chest wall decompression, so that the lung re-expands quickly. But again, the small needle won't sustain the positive pressure removal. It has to be managed with a larger chest tube, because we will have to wait until the cause is resolved, whether it's a spontaneous pneumothorax or a laceration of the lung, for instance, where the air is coming out from. Okay, so the chest tube there will provide a means for that air and blood to escape, again, until the main cause is resolved, either spontaneously. Either the lung spontaneously closes the hole, or after surgical healing of any intervention, if it is done. Again, questions on chest trauma will be signs and symptoms and management. Okay, and the rest will be under chest tube management.